Hi, this is Dr. Aaron Kowaleski here at ECCO Medical. If you're watching this video, we're going to be discussing what's called May-Thurner Syndrome, which is a vein compression syndrome in your pelvis. Patients with May-Thurner Syndrome can have a wide variety of symptoms, but the vast majority of patients can present with left leg pain, left leg swelling, purplish skin discoloration of their foot and ankle. They can develop bulging veins on their leg, as well as even wounds and ulcers. Some patients can even present with a clot in their left leg or DVT, deep vein thrombosis, that would be due to the pelvic vein compression. May-Thurner syndrome occurs in both men and women. However, it does have a slight predilection for women, so it occurs a little bit more often in females. It usually occurs in thinner patients, and it occurs in about 20% of the population. Not everyone becomes symptomatic due to May-Thurner syndrome, and so it's slightly underdiagnosed. So let's talk about what it is and why it does what it does. So May-Thurner syndrome is a compression of the left common iliac vein in the pelvis, where it is squeezed between the right common iliac artery and the spine. So as the right common iliac artery sits on top of that vein, then the spine is behind it, and so it creates this compression of that vein. The analogy I like to use is it's like if they built an overpass on the freeway that's too low, meaning that not all the cars can get through it. Maybe some of the smaller ones can get through it, like some of the blood can get through that vein, but a lot of cars can't. And so they have to find another way to get around that overpass to get back to where it needs to go. And in this case, the blood's trying to get back to the heart. So what that does is it causes a backup of blood flow on that left side, and that blood has to get to the heart somehow. So what it may do is find bypasses or collateral pathways in the pelvis. It may go over to the right leg and come back up. And that can cause symptoms like pelvic pain and left leg swelling, particularly left leg swelling because the blood coming from the left leg is unable to get out of the pelvis and up to the heart. As I mentioned, the blood can try to find collateral pathways to get back to the heart. That can cause some other issues like pelvic congestion syndrome in women, or even varicocele in men. So how do we diagnose May-Thurner syndrome? Frequently, people come in with leg swelling and leg pain, and what we always like to do is evaluate whether or not there's pelvic vein disease that could be causing the overall picture. So we can do what's called venous Doppler or venous ultrasound, non-invasive study where we just look at ultrasound and see if we can see into the pelvis to look for any narrowing. Other things that we can do if ultrasound's not our best option is we can get a CAT scan. So we can actually look at the pelvic veins a little bit more directly to see if there are any narrowings. Also, the clinical picture certainly plays a role. If we have a patient that comes in with bulging left leg veins and a swollen left leg, but the right leg is completely normal, that's going to be a pretty good, if not very good, sign that the patient does have May-Thurner syndrome. There are not a lot of treatment options for May-Thurner syndrome. Surgical options have been attempted in the past, specifically a surgical bypass. The issue with veins as opposed to arteries, veins are significantly lower pressure. So venous bypasses have a very high failure rate and are very, very rarely done now, if at all. The main treatment for May-Thurner syndrome and the gold standard is going to be what's called venogram with stent placement. So venogram is a minimally invasive procedure where we use ultrasound and x-ray guidance and a single needle stick. When I do May-Thurner syndrome treatments, I do a single needle stick into the left common femoral vein in the groin. I use ultrasound guidance to get into the vein with the needle. The needle's hollow. I thread a wire through that needle into the vein. That wire I can see on x-ray, so I know it's going into the right place. And then over that wire, I thread the stent. A stent is essentially a chicken wire metal tube. Okay, so what that does is it goes into the vein. We spring loaded, so we essentially press a button and it pops open to hold that vein open and bolster it in between that artery and the spine. One of the things we also do in that procedure before we place the stent, we want to be as accurate and precise as possible. We use some advanced technology called intravascular ultrasound, or IVUS, or IVUS. IVUS is a literal ultrasound probe that we put inside the vein so we can see it from the inside out. We can get the measurements that we need, one, to confirm that you do in fact have May-Thurner syndrome. CAT scan isn't always going to be the best because that's just a photograph, right? So that vein can expand and contract, but the CAT scan doesn't account for that. Ultrasound isn't going to be as accurate, external ultrasound isn't going to be as accurate as intravascular ultrasound because we're actually inside the blood vessel. And we're watching the veins expand and contract as the patient is breathing. The definition of May-Thurner syndrome is anything over 50% narrowing of the vein. Some people like to use 60%. That's two different studies. I tend to use 60% narrowing. I tend to be a little bit more conservative there. Once you have that measurement confirmed and you know that May-Thurner syndrome exists, that's when you measure the length, so that way you're getting the right size stent length and width. And then you select the appropriate one for the patient and you deploy it there. Afterwards, you balloon the stent open a little bit more. And then patients leave the procedure room usually within about 45 minutes. Patients are sedated for the procedure, so they're very comfortable. They don't really remember anything that occurs in the procedure room, and then they go home the same day. If you do need a stent for May-Thurner syndrome, we will place you on blood thinners for 30 days, prescription strength blood thinners. That's usually going to be Xarelto or Eliquis. And then at the end of that 30 days, we'll switch you to a baby aspirin or 81 milligrams aspirin daily for 1 year. You have interval follow-ups throughout that entire process where we do ultrasound of the stent just to make certain it's staying open and that there's nothing else going on. The success rates of May-Thurner stent placement approaches 95%, meaning that symptoms resolve, patients get better, and no issues with the stent develop. There really isn't another option for this outside of the surgical bypass, as we mentioned, but that has very high failure rates, significantly higher than stent placement. Complication rates are very low. They run in that 1 to 5% range, which is pretty consistent across minimally invasive procedures. In this case, the most common complication is going to be to develop clot in that stent. That's really why we put you on those blood thinners, especially those higher dose blood thinners for that first month, to decrease that risk of developing a clot in that stent. Usually after a year, it's very unlikely for you to develop some kind of thrombosis, although not unheard of, or clot in the stent. Other things that can occur, and rarely, is that the stent can move. This happened quite a bit several years ago. There were numerous stents that were released on the market. The vein market was seen as an underserved market. Every company put out a venous stent, and they didn't really do a lot of research into the technology, unfortunately. And so we saw for a very short period of time a large number of migration events, meaning the stents moved either further into the pelvis, up into the abdomen, and in some really bad cases up into the heart. All of those stents got pulled from the market except for two. One of them is the stent that we use almost exclusively, which is called the Abre, the ABRE by Medtronic. I'm not paid by them, so I'm not trying to pitch them because I get something extra. I just think it's good for you to know about it so that way you can potentially read up on it. When they made their stent, they kind of waited for everyone else to get out on the market and actually see what their failures were, so that way they could re-engineer their stent to make certain it didn't migrate. Migration events with the Abre are down to about 1% or less. That's going to be the best you can find on the market. However, if you do get on the internet and Google, you will find horror stories about that. Just know that with the newer era and the newer generation of stents, those issues that did occur in a significant amount several years ago, those have essentially been figured out, and migration events are dropping significantly and are down to about 1% now. The minimally invasive procedures we do at ECCO Medical are outpatient. You walk in, you walk out, and they're very low impact on your body. We use moderate sedation for the procedure, so you're snoozing or completely asleep throughout the procedure, but we're not putting a tube down into your lungs to breathe for you like you need to do with general anesthesia. In general, people don't remember the procedure. They may remember a flash here and there, but for the most part, you don't remember anything about it. It's safe. We do it here every single day, and we have skilled and trained staff to be able to administer these medications safely. If you have any questions that weren't answered while you were watching this video, or if you think of anything afterwards, please don't hesitate to ask me or one of the providers that you speak with. We're always going to be available, and you can always call us if you forget to ask us something during your consultation.